Yo, yo, everybody, what is up? Your friendly neighborhood physical therapist, Dr. Ryan Welton, coming to you from the Welton residence. Um, today I'm talking about a mystery shoulder pain case. So, I see the medical mysteries in my clinic. I got a clinic where most people have like failed everything type situation. They come in here, they're frustrated, they're, you know, tried all kinds of things. So I call it the I've failed everything clinic that I have, right? I get exceptional results in that clinic. But I usually see like back pain, neck pain, um, you know, hip, groin, something like that. Um, because I feel like a lot of the other stuff, maybe headaches, a lot of the other stuff is pretty straightforward. And so this lady came in the other day and she said, I've tried everything for years, type thing for my shoulder pain. And I'm like, shoulder pain? I'm like, usually, the medical system's pretty good, I find, at shoulders, and physical therapists or so are good at shoulders, right? And so I'm like, interesting. And I was like, so what are your symptoms? And she just said, it kind of hurts in here. And it was vague symptoms. So I was like, oh, I was intrigued because it was a mystery shoulder pain case. And like I said, I don't see those being mysteries like I do for back pain, SI joint, all that stuff, right? And so I'm sitting there and I'm like, if you had x-rays, MRIs, yeah, everything's normal. I've seen PTs, I've seen this, that, the other thing, right? And I'm like, hmm. I'm like, okay, well, so the first thing I do when I evaluate a shoulder is to check myotome strength, right? So I check all her myotomes from C4 to T1. Okay. I check her myotomes C4 to T1 intact, 5 out of 5 strength. And so her myotomes, this patient's myotomes are intact, 5 out of 5 strength. And but like I said, she's a shoulder pain medical mystery, right? No one knows what's wrong with her type situation. She's just frustrated. She actually can't sleep at night, right? So I'm like, hmm. So the next thing I do is I test her rotator cuff, empty can, right? 5 out of 5. Internal, external rotation, 5 out of 5. I check her, I do the O'Brien's test, but I do it very differently than most people. What I have found over the years is that the patient often, like with a crazy high degree of certainty I've found in my patients, that when you hold them like this and do the O'Brien test, when you do that and you ask them, is it because the bicep tendon is right here, right? So people hold their arm up, they got bicipital tendonitis, it hurts, right? And but the goal is to differentiate between bicipital tendonitis and a slap tear, right? But what I found is that the patient knows if you ask them. And I asked her, I said, when I hold it like this, I say, is that pain that you feel here deep or superficial, like in the joint or a muscle? And I look them right in the eyes to make sure that their degree of certainty, right? So I want to know that their degree of certainty is like they are certain it's superficial, or they are certain it is deep, because they'll tell you. And she said, no, it's more superficial. So I'm not thinking it's a slap tear. Okay. So, so I'm like, okay. I'm like, I started to get a feeling of what this was, because there's one condition I find that is patients struggle to get a diagnosis. And so I take her arm and I put it in a 90-90. And I go like this, like an apprehension test type thing, but she didn't have apprehension. What she had was sharp pain in the back, right in there. And I said, uh, I wrote a paper on this that statistically made medical history. And So I had her go like this, and she felt sharp pain in the back. Okay. And then I also put her in a Nears test, and she had sharp pain up top. So I was like, okay, well, I think I know what's wrong here. So the Nears test indicates an impingement syndrome. It doesn't confirm it. It indicates it, if you ask me. Okay. So what confirms it, okay, is to do a relocation test. Okay. Now, in my paper on posterior impingement syndrome, when the glenohumeral joint, you bring them a 90-90, and impinges the posterior labrum, or it can actually impinge the rotator cuff. It impinges the posterior labrum, then that is a positive, and it pinches, that is a positive test. But in the paper, I looked at what everybody had been saying for years, and I created this protocol that, in my belief, one day will prove that this once and for all is caused by a tight posterior and sometimes inferior capsule. And I know that because what I had that patient do is I took the head of her humerus, and I pushed it posterior and inferior in the position of pain. They have to be in the position of pain. If they're not in the position of pain, then you're wasting your time because the patient won't know. Okay. So you put them in the 90-90, you have them say, do you feel pain right there? Yes, they say. Okay. Keep it right there. And when I put my hand on them again, I say, do you still feel pain? And yes, because I need to make sure about what I'm about to do if it changes anything. Okay. This is how you diagnose mechanical issues, is to actually move the mechanics of the joint. And if it relieves the pain, you just found out what was wrong. So I pushed it, her humeral head, posterior and inferiorly. Okay. And I held it there. And she said, yeah, that's better, but it's still there. So then I pushed it even farther posterior inferiorly. And she's like, no, that's gone. And I said, okay, got it. And then I had her raise her arm up, okay, and to a Nears test. And she said, ow, 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 right here, at the rotator cuff, where the rotator cuff's being impinged. And I said, do you have that pain right there? She said, yeah. Same thing I wrote in my paper, my rehab results course, all that is I push posterior and inferior, and I hold it. And I say, now find it. And they can't find it anymore if you relocate it correctly. So what I've found in my patients, in my clinical experience, is that the cause of impingement syndrome, yes, they have muscle imbalances. I mean, this lady had terrible posture, muscle imbalances, tight pecs, tight, a weak parascapular muscles, but they have a tight posterior capsule and sometimes inferior capsule of the glenohumeral joint. And when you mobilize it, posterior inferior, when you mobilize it, then the person says the pain relieves. Not only did you just find out what was wrong, but you found out what to do about it. Okay. So when it comes to mechanical issues, the mechanical issue you will give you the answer. Like SI joint, right? In my paper I wrote root cause of SI joint dysfunction that statistically made medical history as well. It went viral and continues to go viral to this day, 5-6 years after publication, is because you can just check, right? So in there I say that SI joint, I propose, is caused by an upslip and or outflare. Here are the cases, blah, blah, blah. And I show you how I diagnose it, and then I show you how I realign it. So I pull on the person's leg to realign the upslip, and I open the outflares of the pelvis. And when you open the outflares of the pelvis, the person, if the person says they don't have pain anymore, then you just got them out of pain. But you also just found out what was causing their pain. Okay. And it was caused by an upslip and outflare. So, what causes an upslip? Gluteus medius weakness. What causes outflares? Outflares are caused by adductor weakness. Okay. So, when it comes to mechanical issues, if you know what you're doing, not only can you get the person out of pain, but you can confirm what to actually do to help the person. Okay. So in this patient, I pushed her glenoid posterior and inferior. And when I did, and I held it there, I had to push hard the second time because the first time I didn't push hard enough. She said, "Yeah, this feels better. I don't have any pain anymore. Wow, that's crazy." And she's going like this, right? And I said, "Go ahead and find your pain." But I had her in a posterior inferior mode. And she said, "That's crazy. I can't believe my my pain's gone." And I said, "Yeah, so that's what's causing it." I said, "You have something called a tight posterior capsule." Now, most patients don't know what a capsule is, right? So I said, "Have you ever heard of a frozen shoulder?" And they say, "Yeah." I said, "You don't have a frozen shoulder." Because if you put an analogy to something, then people walk away thinking that that's what you're saying they have. They don't. So I'm like, "You do not have a frozen shoulder." But what the technical name for a frozen shoulder is adhesive capsulitis. So in those patients, which you do not have it, but in those patients, you have a joint capsule and it adheses to itself. The next thing you know, the person's going like this and they're in so much pain because it's like scabs and stuff on it. And I say you don't have that, but in the same respect, and you have a tight, restricted part of this joint capsule that stabilizes the joint so it doesn't dislocate. But it's pushing the glenoid anteriorly in the socket. Okay. And when that happens and it pushes the glenoid anteriorly, then the glenohumeral joint becomes dysfunctional the way that it's moving, the biomechanics, it throws off. And they start pinching the posterior labrum in the back or the rotator cuff. And also in superior impingement syndrome, it starts to pinch the rotator cuff in the acromion. Okay, so that's how I explain it to them, and they get it. And not only do they get it because not just because I'm a physical therapist talking about orthopedics, because I actually relieve their pain. And then I told them, "Here is how I relieved your pain," and then they completely understand it because it was a practical situation that they just experienced. You see what I'm saying? So mechanical issues, if you know what you're doing, number one, become easier to diagnose. Number two, it tells you what to do to treat it. But number three, the patient understands more rather than, yeah, you got a strained calf. They'd be like, okay, you know what I'm saying? Like, but if you tell someone they have an impingement syndrome and it's pinching on here, and remember when I pushed it back and down in the socket and I unimpinged it, and we just need to get it there. Okay, so I would put this patient on my shoulder, my posterior impingement protocol and superior impingement protocol, which are almost identical. And then I would expect this patient to get better. I don't have any concerns when it comes to that kind of stuff, whether my patients are going to get better. I just I let the protocol work and troubleshoot it if I need to. But if you join my group, my VIP inner circle, click below here and join my free VIP group. I'm talking more in depth, and I'm actually teaching live with Q&A on and you get 59% off all of my courses. A physical therapist just messaged me who took my myofascial courses and my sciatica course, and she's in my clinical mentorship. And she just said that she has, quote, jaw-dropping results for her and her patients. Yeah, I hear that all the time. I call them reflex pain points in those in the myofascial course when I wrote a paper on it. Reflexively shuts off pain, as I described in the paper. That's what I in those cases. So, anyways, that is that. Please join that group, the VIP school group below. And I'm teaching more advanced stuff. Plus, I'm also teaching my hybrid advanced clinical mentorship. Okay, clinical business mentorship, where I teach you how to open and run a very successful, highly profitable, this is way different than everybody else's cash-based clinic. Everybody's cash-based clinic, everybody's fighting over the same people. I don't have competition, and neither do my students. And the reason why is because we are treating the chronic pain world. It is not scary. It is a lot of these people have mechanical issues. SI joint. I treat it all day long. SI joint. You know, but I mentor you on the clinical part in these in these clinics, people charge $400 for 30 minutes of their time. Do the math. You are, a lot of people don't even work 40 hours. I don't work 40 hours a week. And, do very well, so I teach people how to open and run these clinics, and join that school group below, and I'm teaching for free in there. All right. Other than that, I am out. Peace. Love you all. Check for mechanical issues.